All right, we'll go ahead and get started. Thank you all for being with us for UK Healthcare's Behavioral Health Community of Practice. Today, we're going to talk about expanding access through using alternative visit types. My name is Trudy Matthews. I'm the Senior Director of Quality and Value Strategy at UK Healthcare, and it is my pleasure to be the facilitator today of what I hope is going to be a really great conversation. We do have both a great set of speakers and panelists to present today. A couple of housekeeping items as we get started. So we love to have your interaction and feedback. And so we want to make sure that you know at the bottom of your screen is a button that says chat. That's a great way to ask questions or log questions throughout the presentation, and we'll come back to those questions during the panel time, or we'll also give you the opportunity to ask questions of our panelists later today. So be ready for that opportunity. One thing we also want to make everyone aware of is that as a participant in the behavioral health community of practice, we are offering to all participants, not just clinicians, but all participants, administrators, and folks in a variety of roles, mental health first aid training. You may recall that in our first session in our behavioral health community of practice, we discussed how mental health first aid plays a key role in helping everyone in our practice settings and who are interacting with patients or even out in the community, how mental health first aid can be a key way to train people to interact with individuals who may be experiencing behavioral health concerns. And so we want to make sure that as part of this behavioral health community practice that we're giving you the opportunity to take advantage of this very important training at no charge to you. We'll have opportunities to sign up. Also, it's available through our website as we go through today, but want to make sure that everyone stays on because we'll have a QR code at the end for you to view if you want to sign up right then. It's really a great opportunity. Also, too, we want to make sure to say thank you to all the folks who were part of helping to put together today's community of practice. We have a great team here at UK Healthcare, and I'm so excited to start off our time with our first part of our community of practice today with two great clinicians from our expert team here at UK Healthcare, Dr. Teresa Jebedon, who is Ambulatory Medical Director in UK's Department of Psychiatry. She's also Adult Division Lead at UK's Psychiatry. And then also Steve Johnson, Dr. Steve Johnson, who's Director of Psychotherapy and Psychological Services here at UK Healthcare. He is not only sees patients for mental health and substance use issues, but also teaches residents and graduate students as well, and then is a coordinator of mental health services for our Bluegrass Care Clinic. So they are going to start us off today by talking about connecting with patients through telepsychiatry. Thank you both for being here today, and we look forward to hearing what you have to say. Thanks so much.
What a great introduction. Thank you, Trudy. Well, we titled our presentation this afternoon, and I'm really glad to be here. Title it Screen Time. I don't know how many of you get messages on your phone that say your screen time is up. Well, our screen time is most certainly up, and that has to do for us with telepsychiatry. We go on to the next slide. Did want to mention that neither Dr. Johnson nor I have any conflict of interest to report at this point, unless Steve has something he hasn't told me about.
No, nothing so far today.
All right. All right. Well, in what we call the before times, that is prior to the pandemic, most of our visits, obviously in behavioral health, are face-to-face. Folks come in to see us. That was standard of care. And in fact, although telebehavioral health was out there, it was pretty much limited to remote areas, to facilities, to contractual arrangements. And in fact, we did, prior to COVID, have a contract to provide outpatient mental health services to a remote clinic. That was done via a secure Polycom connection with the doctor's office. So it was a totally different setup than what we're experiencing now. And part of that was due to the fact that there were a lot of restrictions on the use of telehealth in any setting. So it did dampen it down a bit.
Here we might mention too that the department actually won an award for doing telehealth. I think, if you can believe this, 26 or
Yes.
27 years ago. So we've been doing it that long, if you can
Yes.
imagine. Yeah.
Yes, yes. But it was literally about 1% of our volume, close to that. Next slide, please. Then COVID arrived and remote became the rule. All of a sudden, with a lockdown, we had to pivot fairly quickly to telepsychiatry in order to be able to see our patients. We really could not do care in much of any other way. Now, luckily, the restrictions on telehealth loosened enormously, kind of had to. It was a little bit scary at first. I think Steve will agree with me. We wanted to be able to see our patients, but on the other hand, there was a lot that had to happen, both in hardware, software, and just in our ability to connect over this medium before we could really make it successful. I do feel that since we have a really great team in UK psychiatry, we all work amazingly well together, we were able to do, I think, a very good job. We had a lot of satisfaction from providers and from patients, but of course, there were some stumbling blocks along the road and some things that we had to learn to do just a little bit better. Next slide, please. Fast forward to 2022. At this point, I found this, this note from the APA just in the last couple of weeks, and I thought it was really telling. All telehealth prior to the pandemic, not just behavioral, is about 1% of visits. Now it's 10% of all outpatient visits. That's a lot. And of course, as you might suspect, since behavioral health really lends itself relatively well to telehealth, we are at the head of the pack. 57% of all outpatient telebehavioral health visits are occurring now. Primary care is next with 10.1. I would say in my practice, I probably have close to 80% telehealth. I believe with the residence clinic, we're at least 75. Steve, therapy-wise, I think we're right up there too, aren't we?
Right. I did a quick check this morning just to check people's schedules and see what was scheduled telehealth and what was scheduled in person. And for our adult therapists, we are around that 2/3 to 3/4. So like 66 to 75% of our visits are telehealth still. It's a little bit lower with our child therapists, as you can imagine. There are little children on telehealth, and we can talk about this a little bit later, but they're a little different story. So their numbers are more like the 40% range for children, but that's still a huge number.
All right. And agreeably, there are some visits that simply don't translate well to telehealth. And I'm sure that we're going to talk about that a bit more, not only in our discussion, but also in our panel discussion. Can we have the next slide, please? Well, what was our experience? Well, I think number one, the very first thing was that we were able to connect with our patients, and our patients were able to connect with us. A notable thing that was not true 20 years ago is that almost everyone at least has a cell phone. Many people have a computer or a tablet, so they have the means. Now, being able to utilize that might be a horse of a different color, but most everyone has the ability, and a lot of folks found it very, very convenient. During lockdown, when many of our patients who suffer from depression and anxiety couldn't really get out, couldn't access their usual support systems, this really became important to them and has remained so. A lot of people really like it. I think an interesting point, and Steve, I know you found this too, many of our UK HMO patients who are working on campus have difficulties with parking and getting to in-person appointments, loved telehealth. It was a way that they could actually make appointments more frequently and keep up their treatment. Another big plus was being able to see folks, I've said, in their natural habitat. It's an opportunity that we really hadn't had before. With telehealth, we could meet with people in their homes. We kind of saw what was going on. We were able to meet family members that we hadn't been able to meet before, see surroundings, see how folks lived. And that's been incredibly helpful. And it's increased some of our rapport with patients too. We had opportunity for real-time interventions. I have had a couple of patients who have had anxiety about getting outside, anxiety about doing this or that task. We're literally able to walk through it together. And then, of course, for us, integration of documentation. UK is using the Epic EHR platform. It does give us the opportunity to work in our documentation while we're seeing the patient, which can be very helpful too, to make sure that we're getting timely care. But as we all know, there are challenges. Technology is wonderful until it's not. Challenges have been internet and system inadequacies or failures. Systems go down. My knowledge of how to fix something is often not anywhere close to adequate. I cannot doctor that. It has taken a lot of support to be able to make sure that the systems are up and running. Notably, UK did move to the Epic platform in June of 2020, so right in the middle of all the pandemic experience. Did give us an opportunity to learn a great deal, though. As I said, also, some people were just uncomfortable with the technology, just didn't like it. Those folks sometimes have chosen to stay with in-person appointments. Others have said, you know what, I'm going to learn. And one thing we've had to do is be sure that we had the ability to help them with that. We'll say a little bit more about that later, because that is an area that has grown greatly. A major issue for us has been maintaining an engaged and professional encounter. Engaging with a patient in the office where you have the opportunity to firsthand observe behavior, really see those expressions up close, body language. You don't have that opportunity as readily online, right? And how you interact online is a bit different. So being able to adjust the communication skills that we've spent our professional lives learning and translate those to the telehealth medium was a little bit of a challenge, but it's kind of been fun too. From the patient side, most patients that connect online do so with FaceTime, with video chats, with TikTok. This is a professional encounter, and sometimes from the patient point of view, it can get very casual. We've had some locations of patients in unusual situations or in places that might not be fully appropriate. For instance, we've had folks come to a video appointment while they're driving. it's probably not the very safest thing to do. So we've had to be aware of that and set a few limits.
I'll say too, Terry, I think my biggest concern when we started telehealth with psychotherapy patients was that they were not going to feel as comfortable disclosing personal information via telehealth. And so I was concerned of how we're going to do therapy if people aren't willing to really talk about their issues. But I was surprised that for almost all of our patients, it didn't seem to be an issue. And like Dr. Jevin just mentioned, I think for a lot of them that are comfortable with the video medium already of sharing on other platforms, this sort of seemed like a natural for some of them. And when I've really stopped to consider it, in some ways, I think sharing, deep, dark secrets or really personal information sometimes might be easier to do to a camera than it is in someone's office. So I was surprised that some people, it maybe was even easier for them to talk about things. Now, as Dr. Jevin said, there's also the times when they would say, well, I have some things I really need to talk to you about, but I feel like someone's listening in the other room or family's too close right now for me to feel comfortable talking about that. So again, the things that are that make things positive also sometimes are the things that are negative as well. So,
and always the things to keep in mind, because it's a two-sided sword in some ways, and every person in every situation may not be appropriate for a telehealth visit, but in many cases we've certainly been able to expand our reach. May I have the next slide, Kate? So, what if you are getting ready to launch a telepractice, or you want to think about, are there some ways that I could improve my practice? Well, from what Steve and I have experienced, we wanted to just put forth a few tips, and you may have some tips for us too. We're always ready to learn. If you're getting ready to launch, station, software, security, and support are first. You really can't do a telehealth appointment if you don't have the video capacity, correct? Let's go to the next slide, Katie. Hardware is a foundation. You do need a reliable computer. You need to be able to have a good webcam and hopefully one with good resolution. HD is optimal. Many of the newer computers are great in terms of their video capability, because video is very important these days. But some older computers, desktop that I had at home, not so much. I did need to upgrade. Now, I do prefer a desktop. I have dual screens. Steve, I think you have a dockable laptop, do you not?
yes, that's what I'm coming to you now from.
Well, see, you may have an integrated webcam. You may need to add a webcam, but the webcam is obviously very important. If the other party cannot see you, then the ability to make that connection fails. Likewise with sound. Oftentimes the microphone and the speakers that are indwelling on your desktop may not be adequate, and background noise can be incredibly distracting in an interview. We found that optimizing with a headphone or with earbuds, these are simply the earbuds from my mobile phone. They work pretty well. Some folks, a couple of our residents, have high quality headsets. All of that can be helpful. You want to make sure that the person you're connecting with can hear you. Carefully consider where the computer is and the lighting. Obviously, you want to be in a secure area. Like Steve mentioned, being able to speak openly about sensitive subjects and knowing that the person that you are communicating that with can keep that information secure as well is the basis of psychotherapy. So we want to make sure that our patients know and that we know that we're in a secure location. Lighting's important too. If you have your back to the window and sunlight is coming in, you're going to look a little bit scary. It's going to be sort of like the moon. It's not good. Having a light in front of you, even a desk lamp or a ring light that are very popular now, can help you be seen. And then obviously adequate internet speed. Another issue I had when trying to work remotely, my initial internet speed was just not fast enough to handle video. So I needed to upgrade. And that is important. If not, there's going to be a lot of pixelation and there's going to be difficulties in maintaining your connection. Again, not only does that interfere with connection technically, it interferes with the interpersonal connection. Next slide, Katie. Well, of course, that leads us into software. Incredibly important. Electronic medical record is the best. I know there are folks out there who are using paper records and connecting with the patient through a telebehavioral health appointment, but using paper records, it can be just a little bit more difficult. There are a number of integrated systems out there. As I mentioned, UK uses Epic. In fact, the entire platform is integrated, including the video visit. Other folks are using Zoom. Would be important to make sure that you have full capability for not only if the medical record, if you want it, but also scheduling capability if you're in private practice, and a billing and payment solution online can help greatly. You want to research the options, and you definitely want to try before you buy. You want to ask a lot of questions. It's incredibly important. You can spend a lot of money on software that either isn't appropriate for you or doesn't work for your particular situation. Which brings me to the next slide, Katie. Security. This is tantamount. HIPAA compliance is absolutely required. That's the reason it's not a good idea to do video visits on FaceTime. It's not a secure medium. Facebook's not a secure medium. HIPAA compliance is an important part of an integrated system for the patient, for you, the software, the devices that you're using. Make sure that any platform that you're utilizing is HIPAA compliant. Verify the encryption standards of any video vendor. And also make sure that the vendor does not intercept or store video. That's another potential leak that could be a huge problem. Next slide, Katie. And how do you do all this? Well, needless to say, I'm certainly not an IT expert. Steve, you may be an IT expert in another life, I'm not sure, but I think you and I are about at the same point.
I think you're ahead of me, Terry, for sure. But yes, we definitely needed really good support to make this happen for all of us.
Absolutely. We never leave home without our support, that's for sure. For those of you in private practice, check out the availability of support via your video vendor. Some now do include support for your system, and that's something I would definitely recommend. Hire or train an IT support person. Now, I want to mention something here. At UK, we are using the UK IT. They've been wonderful with us. It's been great. However, that doesn't always translate to the patient side of things. My side of the system may work great, but my patient can't quite get everything to work. SAMHSA the Substance Abuse Mental Health Services Administration is now sponsoring trainings for digital navigators. So if you want to obtain training or have someone in your practice obtain training to help patients to navigate this platform, that's now available, which is really wonderful. We've been very lucky here in psychiatry. We have a couple of folks in our registration pod that have been wonderful at helping patients connect. I would suggest also consulting with a financial advisor as well as an IT advisor and a legal advisor. You want to make sure that you're doing everything according to the highest possibility.
I'll say, Terry, just throw this in too. It was helpful for a lot of people early on that, especially if they were using their smartphone, because some platforms you have to do something different with your speakers and your microphones. And so our support folks were able to do a test run with some of them, and they did that here at Bluegrass Care Clinic as well, where they were able to contact the patient, set them up, do a call, sort of do a trial run so that, you know, that decreases the anxiety of, oh, I have an appointment with a doctor at 1 o'clock and I don't know if my equipment's going to work. So having those, you know, dry runs and having those practice sessions with patients was also huge in decreasing their anxiety and using the new technology.
Absolutely, absolutely. And also for folks knowing, some folks will connect with us from their home on a desktop or laptop, but they also have the phone. And sometimes they forget that they could use either one. Next slide, Katie. And before blast off, for sure, you want to make sure that you've researched the licensure boundaries, billing requirements, credentialing. We have had several occasions when a patient has been traveling and they want to attend their video visit. However, they're in Tennessee or they're in Missouri, and we don't have licensure there. It does take a special permission to be able to do that, or you need to have licensure in that state. So you want to be very careful of that. We don't want to get sideways of state laws. Insurance payers may also require special credentialing, and be careful of your documentation. It needs to reflect that this was a video visit, how long it was, whether it was audio and video or audio only. And CPT codes need to reflect that it was a televisit as well. The 95 modifier accomplishes that. Katie, I think we're blasting off. Now, this is the very best part to me, making the connection. We mentioned a few minutes ago the importance of applying our communication skills across this medium. Katie, go ahead and move us along. We need to be there for there to be quality care. It's important that that connection that we have learned through our training to establish with patients in person, that be communicated as much as possible through the video visit. Next slide, please. So came up with a few tips. You all may have more. Be sure to share them. Katie, there needs to be a quiz at the end for tips from other folks. But the first one we came up with was to be comfortable and prepared for the session yourself. Make sure that your setup's working. Make sure that your camera is working. There is nothing that can kind of spoil a visit faster than trying to fumble to get it working, right? Make eye contact. That's the most important thing. And eye contact is looking at the camera, looking at the person. That's the difference between looking at the camera and looking, yeah, there you are down there. I see you. Hi, Steve. How are you? Looking at the camera maintains the eye contact. Make sure that you can hear and be heard. Sometimes that means slowing down your speech a little bit. Again, I do believe in the use of earbuds or a headset can be really helpful in being able to be heard. If the person can't hear you, it's hard to communicate. And smile. For heaven's sakes, that helps with connection almost more than anything else. Katie, you're so good. Pay attention to the interaction. One mistake that often is made by young doctors coming in is, again, I have two screens. If I'm focused over here, trying to write in the chart, that really doesn't allow for that connection to continue. I oftentimes do need to get something from the chart or do need to order a medication, but I try, at least this is my intervention, I try to say, hey, let me look over here at your chart. Let me look in the medications and see if you're going to need a refill or what we can do to assess whatever issues going on. The patient know what's happening rather than looking like you're distracted with something else. If you see something, say something. If something's going on in the house, there's another person there, say something. Oh, hey, it looks like you have company. Who is that? Oh, that's my mom. I may give you a wave. Oh, you didn't know mom was living there. Or the patient may say, yeah, no, I'm not alone. And okay, then you kind of know, there may be more that we need to discuss in another interaction. Also, oftentimes you will notice when seeing a patient at home, whoa, look, there's the dog, or the dog may be barking. They may get embarrassed that this interruption is happening. Hey, that's great. Mention something about that. I have had the best connection with some folks over their pets that I didn't even know they had prior to this. Really important parts of their life. And we can kind of share some things about that really helps the rapport. So say something. If you notice a trophy or you notice something, oh, really? Didn't know you did that. One of my patients was worried and suffered a lot of depression. I noticed we were doing some video visits, there were these great paintings. And finally, I said, those are beautiful. I noticed the paintings and several of them there. He tells me he did those. He is an artist. He was great. That was an important thing to know and something we've been able to use in his treatment. And finally, you may want to identify where the person is and who they're with. Not just to know, hey, can we continue this visit? Are you in state? Are you not driving or in a tenuous position? But it can be very helpful, particularly if it's someone you're worried about safety. Are they at home? Are they out in a car? Where are they? In case you do need to contact emergency responders. And again, who are they with? Are you with anyone? How is that? Is that a supportive person? And so forth. Oftentimes folks really appreciate that you want to know, that you are interested in what's going on with them. Anything to add there, Steve?
Probably the one other tip that I would give you, and if you've been doing this, you know this probably to be true, is that, you know, when we are seeing a patient in person, if we're running a few minutes late, it's not that big of a deal. Folks are in the lobby waiting. You know, of course, we don't want to ever keep people waiting too long for their scheduled appointments. But I've noticed that on telehealth visits, I try really hard to be right on time because people get anxious if you don't show up, that they think they don't have the right connection or something, that they've done something wrong. And so it's important, I think, especially if someone's new to telehealth, to this platform, that you really try to be on time for their visit so that they know that that technology hasn't failed.
Exactly. Okay, Katie. And I feel that telepsychiatry, it's not a panacea. It can't fix everything. It's not for everyone. but it certainly has the potential to expand mental health services, already has. It's convenient, can be efficient, and can really bring those who might have barriers to otherwise engaging in treatment or engaging in treatment as frequently as they need to, but give them that opportunity. It requires a little bit of adaptation on our part with skills, communication skills and technology, but boy, it can be really gratifying. Now, if you are interested in learning more, most professional associations at this point, including the American Psychiatric Association, have professional telehealth resources available. Next slide, Katie. Right now, I just became aware that both KMA and on the next slide, the AMA, Kentucky Medical Association and the American Medical Association, are both offering some trainings in the next week or so. So if you're interested in that, it might be worth a look.
It won't be as good as ours, but it'll probably be pretty good.
Well, it's true. That's why I put it on. Thanks, everyone.
Great. Thank you both so much for sharing your insights. We're going to go to a poll question. So if you guys could get ready, we're going to ask a question and you'll see a poll pop up, and we'd love to get your feedback. The question is, how many of you use telehealth in your practice or clinic? So we get kind of the always, sometimes, never opportunity. So we've got, there's some folks on here are not in a clinical setting because we're administrators, so we'll not respond. Looks like we've got most everybody who's responding. Looks like about the nevers are currently about 25%, sometimes 58%, and always 17%. I'm surprised by the always. Because that's a pretty high number still for some of the participants to be using. Any comments about that, Dr. Jevon or Dr. Johnson?
Well, I do know that there are some providers right now that are employed by telepsychiatry companies. So their practice would be totally telepsych. If you are working in some of the prisons, it may be totally telepsych. So I know that there are those options out there.
Yeah. Good feedback and commentary. All right. Well, now we're going to pivot and go to our panel. We're going to add another friend to the mix here in terms of our discussion. We'll have our two speakers from previously, but also joining us is Tiffany Arrows Price, Dr. Tiffany Arrows Price, who works with New Vista as Regional Director for Specialty and Outreach Services for New Vista. And Dr. Price has over 22 years and multiple roles in the health system. So we are delighted to have her with us. Thanks so much for being with us.
Thank you for having me.
Okay, so this is the opportunity for those of you who are listening. If you want to add anything into the chat or any questions, I'm happy to field those with the speakers. But we also have a few questions we want to kind of tee up here with you all. So, you know, as you all have done telehealth, of course, to some degree, we talked a little bit about this, but what are some of the best practices that you follow? Anything else that you'd want to share in terms of what you think really works for you in your practice related to telehealth? Anybody just jump on in.
Really, I think the training has covered this very well. There's two tenets that we hold so dear in mental health, and really that's confidentiality and making sure that we have the right platforms, that everything is secure, that we have, our environment is secure and safe and their environment is secure and safe before we start, and all of that is put together. And then also making sure that we have the correct consent, that we've talked to the person about their comfort level in using telehealth, that they are on board with knowing that this is a safe, effective way to deliver services, and just always making sure that those two things are primary before we even start is really important.
That's great, Tiffany. I echo that for sure. I had a patient this morning that I actually saw in person, and as he was walking down the hallway, he goes, "Oh, I'm so sleepy." He said, "I think next time I'm going to do this as a telehealth appointment." And he'd never done that before. And I said, "Sure, that's always an option if you want to do that." And I think, we're very lucky at our clinic in psychiatry that, and I'm sure New Vista as well, is that we have that option to offer both for patients. And so I think that's a thing to keep in mind and remind them that they have that option of, if it's not convenient to come in for an in-person visit, then telehealth is certainly an option for that. And, it may help with folks being able to be seen more regularly because, as Dr. Jevidan mentioned, if you're at UK and you're one of our patients, you get to leave the parking garage, drive 20 minutes over to our clinic, come in for your session, and then hope when you get back to campus that there's a parking space. So, and that may be the case for lots of other folks in other institutions. So it really is hugely convenient for lots of folks.
It is. And I think Steve, you're exactly right. Having the opportunity to choose has been very helpful for some of our patients. With the price of gas right now and a number of folks living far outside the county, it's also been a financial help for many folks. Now, that said, and I guess this kind of is leaking into the next question, Trudy, but there are some times that folks really do need to be seen in person. Some of the substance use cases, folks who need to come in to get vitals done. There's all sorts of things that might need to come in or be seen at least once in a while in person.
Yeah, that was going to be my next question. Are there ever, what are some of the criteria for using telehealth versus beyond what just the patient has expressed as their wishes? What are some of the other things that you bring to bear in terms of making that decision? So Dr. Jevidan, you provided some good examples there. Anything else that you all can think about in terms of the types of services or care that you provide telehealth versus in person?
Sure. And I think there's plenty of research that supports that most services work well with telehealth. We keep outcome measures here at New Vista, and we have demonstrated well that the outcomes remain positive even after a significant switch over to telehealth with the pandemic. So that's all really great news for accessibility for folks who have traditionally had a difficult time making it into clinic in person. That they are still able to access care and maybe even more often just as effectively. Now, my programs do offer some alternative ways to access care, because when you're working with serious mental illness, folks with a locus level of 4, arguably maybe not the technology that is well suited for telehealth, maybe some cognitive deficits that would make it difficult. What do we do then? Because these folks still need access to care. And I think one thing that we have been able to do well, utilizing the ACT team, which is assertive community treatment, is we have support staff. ACT is a whole interdisciplinary team. And we've been able to send support staff out with tablets, with laptops, with our work smartphones, in the HIPAA compliant platforms and all of this, to link into other providers. Maybe if they couldn't get to them right away, but there's a crisis or we need an assessment, we can link right in with other staff and get to our provider, get to a clinician, and even using some assistive technology, getting into primary care, an initial step in. So I think there are other ways that telehealth can continue to grow to make sure that we are overcoming the barriers that are in place for folks to access.
I really appreciate that, because there is going to be a range of needs for some patients, and kind of providing suiting the intervention and the model to the patient's need is a really great way to go. I know in a previous community of practice, we talked about doing screening, how important that is, and really looking at how UK Healthcare has rolled out a really enterprise-wide screening for depression and suicidality, and kind of how important that is, and being able to capture, patient needs. How do you screen effectively using telehealth? Can you give some thoughts on how you all handle that as behavioral health clinicians?
Sure. We at UK, we have, we're fortunate to have our medical record that screens, that asks the patient to screen before they're seen for their visit. But of course, there's nothing as effective as the clinician screening during the visit as well. So we try to do a dual approach of having that pre-screening before the visit. Sometimes most patients will be able to fill that out. Some patients, they're running late and they don't have time to do it, or they didn't realize they were supposed to do it. But we never want to not do that if we feel like a patient is at risk, because nothing is as important as clinical judgment in working with a patient. So we make sure that we always do both if we're able to.
I think it's been interesting too. The PHQ-9 and the CSSRS are loaded into Epic, and we do utilize those. It's been interesting that sometimes what a patient will tell you in a session differs from what they've marked on their screenings, and it gives you an opportunity to be able to say, wait, let's take another look at this. What's this about? And that's really helpful. But I agree with Steve. There isn't an interaction that goes by that we don't want to make sure that we are screening for depression, suicidality.
Dr. Price, anything to add to that?
They really hit it. The process and instruments that we use are consistent with in-person. So we've not found it to be problematic.
Excellent. Well, let's go back to the point that Dr. Price brought up, really just about the inequities and barriers that patients might have in accessing or using telehealth, and maybe what you all in practice have done to make sure that we're addressing those things. Anything that you can think of for our listeners related to how to deal with specific barriers that patients might be experiencing?
I'd like to underscore the importance of the ACT team for the seriously mentally ill folks. That's wonderful. And that outreach is great. One difficulty that we experienced primarily early in the pandemic, although it's still an issue, is limited internet availability for patients that live in rural areas. One intervention has sometimes been folks will literally drive to the library, to the county seat, places that are allowing free Wi-Fi.
The parking lot at Taco Bell sometimes.
Yes, Taco Bell? What is the deal with Taco Bell? Apparently
Free
they
internet, right? Yeah.
the whole parking lot, and some of the McDonald's too. But we'll drive to obtain internet connectivity. It's been an interesting way to solve one problem, but internet capability has been a big issue.
I'll add to that, Trudy. There's another flavor to this is we've been talking mostly about our adult patients, but we also, at UK and I know at Vista, we have pediatric patients that we see as well. So that's been a little different challenge. And just like with the adults, there are pros and cons. For kids, telehealth is great because, they don't have to leave school, or they can go to the counselor's office at school and use the equipment there, so that they're much less time disrupting instruction time for them. But what we saw early on in telehealth in particular, and talking with our child psychotherapist, is that it's very, children were screen time fatigued, right? When school
Yeah.
was all
Right.
online and they were having to be, do school on their computers and their tablets, coming to a psychotherapy session and spending more time on their screen was really, really hard for them. And so the way we sort of pivoted with that with our child division folks, where they would spend probably, depending on the age of the child, 10 or 15 minutes, maybe telehealth until, that was about all they could sustain. And then the rest of the visit they would spend with parents doing parenting techniques and talking about things they could do with their child, or, more of a family dynamic where there was a little more time spent with actual parents in the session, which in some ways was another benefit that maybe we didn't have before. But as Dr. Jeviden mentioned, you're able to see so much of the interaction between the parent and the child. You're able to see the home environment of the child. They're able to show you their toys that they like to play with. So it really was, again, some really unexpected positives and a few obstacles that we had to deal with the pediatric population.
I wonder too, Dr. Price, because, of course, we're partners with, UK's partners with Vista in the Bluegrass region, but some of your community mental health center colleagues also probably have similar capabilities around the state to intervene and to do. I don't know if you have anything to add, and kind of like for folks who are in other areas outside of New Vista's service region, if they have needs with some of these patients or barriers, what your recommendations would be for them, and kind of helping working with their community mental health center to get access for their patients.
Sure. My understanding is that the other community mental health centers at this time also have ACT available in most of the regions. And so I think if we're looking at barriers due to SMI symptom burden or SMI folks living very rural and not having the technology involved, maybe this is a good time to look at who could be referred to those level of services and reach out and see what could be done on that level. Or even if, is case management adding on needed to help with that education and linking to care, short term, to see if that can be the link to what needs to be done. But, the community mental health centers really should be able to provide some of that support to help people overcome some of those barriers in every way possible. I know there are a lot of barriers out there, but there should be some resources for that, I would think.
Yeah, absolutely. I think that's really great to point to those resources, and having a rich relationship with the community mental health center and the region is really important for healthcare providers and hospitals and health systems. Well, good. Well, we are rapidly coming upon time, so I want to thank our panelists and presenters for sharing their expertise with us today. Thank all of you who participated with us today, and certainly the crack team here at UK Healthcare, folks who put together our webinars at the Kentucky Regional Extension Center, and our Healthy Kentucky team who are helping to put together our session. So we really appreciate everyone being involved. Just a couple of reminders, Katie, if we could go to our mental health first aid training. You remember how I promised you at the beginning that there would be a QR code? There you go. I encourage you to scan it. So we really, really encourage everyone I'm signed up, as a matter of fact, for January session, and really looking forward to that, and just want to make sure that everybody knows that training is free. It's not just for providers, and it's valuable for all roles, clinical, administrative, etc. Scan the QR code from the slide and it'll take you to the website after the webinar, and you can sign up through there. There are a variety of times. We're really pleased to be partnering with our College of Ag on offering the training. We have a certified mental health first aid trainer who really does a great job. And so we're so excited to be able to offer this to everyone who is involved in the behavioral health community of practice. Also, next is going to be a QR code for our survey, and we'll also send out via email to everyone. We really love to get feedback from you all on the content that we're doing. User feedback is the absolute best thing to have for us to make sure that the content that we're providing is helpful to you. If you have any thoughts on what we could do in future sessions, things you'd like to see, please let us know. We really want to hear from you. And then just a reminder that our next session is going to be on January 5th at 12 p.m. at noon. And we are super excited to have another great session for you. This will be on pharmacological interventions, how to integrate those into primary care and using evidence-based guidelines for treatment. So a lot of good information there for that. And I want to say just to everyone, since this is the last community of practice at the end of the year, happy holidays, everyone. I am truly mindful of the rare privilege it is to work here at UK with such a wonderful and talented set of people. And then also to be able to work with all of you in the position that I have and really helping to deal with what has been a tremendous mental health crisis in Kentucky, and really trying to find better solutions and ways to share happier or share faster and better the good news that we have here, that there are solutions and really help for folks. And hopefully you all will also get a time to rest and recharge over the holidays before we see each other again. So thank you all for your time today, and we wish you the very best. Happy holidays and Happy New Year. Thanks, everyone.